Hey guys, my name is Amer Mohiuddin and I'm an MD candidate with IU School of Medicine, and I'm going to be giving a brief overview of rapid sequence induction, or RSI. So RSI is an anesthetic technique designed to minimize the risk of aspiration of gastric contents into the lungs. The goal is to intubate the trachea as quickly and safely as possible following induction, while reducing the chance of passive or active regurgitation. Rapid sequence induction should be considered for patients who are at increased risk of aspiration with induction of anesthesia. This includes patients with a full stomach, which may be the case during emergency surgery, trauma, or patients who have not fasted according to preoperative fasting guidelines. Furthermore, patients with GI pathology may require RSI. For example, patients with gastroparesis, commonly found in diabetic patients, patients with small bowel obstruction or strictures, or patients with a history of GERD may all benefit from RSI. Finally, patients with morbid obesity or ascites are also at increased risk. One thing to note is that patients who regularly take PPIs or H2 blockers should be instructed to take their usual medication before surgery. A rapid sequence induction can be described with the 6Ps of RSI. The first P, or preparation, involves recognizing the indication for RSI, setting up the equipment, and proper positioning of the patient into the sniffing position, oftentimes with the head of the operating table elevated. The second P stands for pre-oxygenate with 100% FiO2 for 1 to 3 minutes, increasing the oxygen reserve to provide additional time to secure the airway. This is especially important for RSI because this technique does not involve mask ventilation between induction and intubation. Next is pre-treatment and induction, most commonly involving an anxiolytic, lidocaine, fentanyl, and propofol. The fourth P is paralyze. Neuromuscular blocking agents are required to achieve optimal intubating conditions and to prevent coughing, gagging, and vomiting as a result of airway manipulation. Succinylcholine should be the agent of choice due to its rapid onset of action. However, if contraindicated, an increased dose of rocuronium is also very effective. The fifth P stands for pass the tube, with either direct laryngoscopy or video laryngoscopy, usually 45 to 90 seconds after the paralytic is pushed. This is often done with the addition of cricoid pressure. However, it is important to note that the efficacy of cricoid pressure is questionable. The sixth and final P stands for post-intubation management, which involves verification of the tube placement and strategy of failed intubations. Some complications of RSI include failed airways, hypoxia, hypotension, regurgitation, and possible aspiration. Thank you for listening.